All right, I think we'll go ahead and get started. Thanks for coming today, and I'll just apologize right now for the occasional cough that I have. Hopefully it's only occasional and not as more often as it has been. Today we're going to talk about antifibrinolytics and trauma. And so what I thought I'd start off with is why trauma patients die. And if you look at this, even though the study is back from 1995 from the Journal of Trauma, of the patients who make it to the hospital, still bleeding and exsanguination still is one of the leading causes of in-hospital deaths in our trauma patients. Of course, head injury being number 2. When you start looking at uncontrolled bleeding in in-hospital patients and you start looking at the other disciplines, trauma surgery is disproportionately in the lead here. Of 30 to 40% of patients who die from uncontrolled bleeding are trauma patients compared to urologic surgery or orthopedics or some of the others. I mean, lap chole is almost non-existent. Even open hearts, we're still significantly higher than open heart surgery. So when you look at our clotting system, there is a delicate balance intravascularly behind the activities that go on the clotting side and the bleeding side. So in order to maintain normal hemostasis, we have fibrinolytic activity, which is balanced on the opposite side by antifibrinolytic activity. And we have procoagulant activity, which is balanced on the opposite side by anticoagulant activity. So there's a lot of things going on to keep us at that perfect balance. And it doesn't seem to take very much to disrupt that. Coagulopathy after trauma has been defined as any perturbation of coagulation. And this impaired clotting was thought to be caused by iatrogenic causes. Hypothermia, we let them get cold in the trauma room, acidosis, and hemodilution from all of the water and fluids that we give them. This hemodilution then resulted in impaired protease cascade activations, impaired thrombin production from the pathways, reduced platelet function, and then dysfunctional fibrinogen activity. However, in 2003, Brohe and company showed that 25% or more of trauma patients who were severely injured presented with significant coagulopathy, which was unrelated to fluid administration. So it really wasn't everything that we did. This has been termed the acute traumatic coagulopathy or acute coagulopathy of trauma shock, ATC or ACOTS. It's associated with increasing transfusion requirements, higher ISS scores, organ dysfunction, and higher mortality rates. And it's defined as an impairment of hemostasis involving dynamic interaction between endogenous anticoagulants and fibrinolysis that is initiated immediately after you're injured. So this starts out in the field. It occurs anywhere between 25 and 40% of severely injured patients when their injuries are combined with shock. It's independent of iatrogenic causes, and it's associated with those 3 things. And studies have suggested that this is due to the activation of the protein C system. So we all remember how this works. I'm just kidding. I had to go back and try to remember all of this stuff. So this is the endothelial lining of a vessel, and when it gets injured, it releases TPA. So that's released from the damaged endothelial cell. At the same time, the endothelial cell produces more thrombomodulin. That's what TM is. And this reduces blood clotting by converting thrombin, which we normally associate with a clotting enzyme. And it changes it from a procoagulant to an anticoagulant. So thrombomodulin binds thrombin and changes it to an anticoagulant. Then the thrombomodulin thrombin complex finds activated factor or protein C along with its cofactor protein S. Those are activated, and they inhibit and decrease factor 5A, the activation of factor 5A and the factor 8A. So the intrinsic pathway is then inhibited, so that not only it stops our intrinsic pathway, but as we go on, this complex then decreases this production of PAI, which is an inhibitor of TPA's effect on plasmin. And so not only does it affect the intrinsic pathway, but it also affects and increases fibrinolysis. And in addition, plasmin, which is a result of fibrinolysis, directly inhibits platelet adhesion and aggregation. So the intrinsic pathway is affected, fibrinolysis is affected, and the platelets are all affected. And this is all resulted from the activation of protein C, and this is believed to be the cause of the acute traumatic coagulopathy. And like I said, all this is going on before they show up at our door. So fibrinolysis simply is the process that prevents blood clots from getting bigger. There's two types, primary and secondary. Primary you don't see very often. Most often it's secondary, and that's what we're talking about, is it's caused by some other reason, not an intrinsic genetic problem in somebody's fibrinolytic pathway. In fibrinolysis, the fibrin clot, which is the endpoint of coagulation pathway, is broken down, and the main enzyme, which is plasmin, cuts up the fibrin mesh, and that gives you your circulating fragments, also known as fibrin split products. So it's fibrin cut up into pieces, gives you your fibrin split products. So if we use a little cartoon and talk about the initiation phase, TPA is released from the endothelial cells, which are damaged, and it converts. So here's TPA, looks like Pac-Man, released in the endothelial cell, and it converts plasminogen, which is an active precursor to plasmin. So that's what we have going on here. And so when the TPA and the plasminogen bind on fibrin, it's activated, and the plasminogen is now plasmin, and it starts breaking down the fibrin. After that starts, it's almost like a self-fulfilling prophecy. As it cuts pieces, you see there's more and more smaller pieces with all these lysine amino acids open on the outside, and that is the binding site for plasmin. So it kind of creates more binding sites for itself, and it propagates this fibrinolysis. That's how normal fibrinolysis works. So plasminogen is the inactive precursor to plasmin. It's produced by your liver, and it binds strongly and has an affinity for fibrin, and it's actually incorporated into the fibrin clot when it's being formed. Plasminogen is built in to the clot of fibrin. TPA, or tissue plasminogen activator, is a serine protease that's released in the endothelial cells. It's released when it's damaged, and of course it activates the plasminogen, which is already sitting there waiting in your fibrin clot to be activated in order to eat it up. So if we look at this is fibrinolysis simple. So thrombin, which is an endpoint of the intrinsic pathway, comes down. Fibrinogen is then converted to fibrin. So here's our fibrin formation side. On our fibrinolytics side, plasminogen is activated by TPA to form plasmin, and plasmin breaks down fibrin, which leaves your fibrin degradation products. So that's this simple. So when we start to add the control mechanisms, first, as plasmin is formed, when TPA lyses plasminogen to plasmin, now it's active to lyse fibrin. It acts as it's on TPA to activate it even more. So it increases the activity of TPA and urokinase to lyse more plasminogen to plasmin. In addition, fibrin itself binds to TPA and activates that even more. So it makes more, stimulates more, makes more, stimulates more. On the opposite side, there's a direct inhibitor, PAI1, plasminogen activator 1, which directly inhibits the effects of TPA. Then, two other proteins are involved. Alpha-macroglobulin and alpha-2 antiplasmin will inhibit plasmin. However, if plasmin is bound to fibrin, it can't bind to it. So TAFI, which is this thrombin activatable fibrinolysis inhibitor, or TAFI, releases plasmin from the fibrin so that alpha-antiplasmin and alpha-macroglobulin can interfere and prevent the breakdown of fibrin. So this is the simple fibrinolysis feedback. So when we start looking at antifibrinolytics, the mechanism is going to be involved in preventing the breakdown of fibrin. So the way that the antifibrinolytics work is that they interfere with those mediators, leading to increasing hemostasis. The original indications for antifibrinolytics were limiting blood loss and coronary bypass and reducing bleeding in hemophiliacs. Inpatient uses, which are all off-label, have been reducing transfusion requirements in surgery and reducing mortality. Antifibrinolytics have been around for a long time, more than 40 years. Most of them are lysine analogs, the two that we are familiar, epsilon aminocaproic acid and then tranexamic acid, or TXA. They are lysine analogs, look very similar to lysine, the amino acid. They bind to those lysine receptors. In that little cartoon I showed you, there were lysine receptors on the plasminogen, and they prevent the activation, so plasminogen doesn't get converted to plasmin, and the plasmin then won't be there to break down fibrin. There's one other, aprotein. It inhibits plasmin once it's been formed, so it doesn't stop the plasminogen to plasmin, but it blocks plasmin's effects once it is formed. When you look at the pictures of these, this is the amino acid lysine. This is Amicar, or epsilon aminocaproic acid, very similar. It has an amide end and a carboxyl end. It's only the chain in between. And then when you get to tranexamic acid, they just added a ring, a 6-carbon ring, with the same ends. So we'll explain this with some cartoons. This is probably the best way I can understand to try and explain to you is plasmin formation requires fibrin. So we have our German Shepherd here, he's got a wrap around his mouth so he can't bite anybody. This would be plasminogen. And this little triangle here is the lysine binding site. Over here, we have TPA with a little pair of scissors. And then when you look at fibrin, as we saw, fibrin has a little lysine binding site. So what's going on is plasminogen with this little lysine binding site binds onto fibrin. TPA shows up with its scissors, releases the German Shepherd, so this is gone, and now the dog's angry and it chews up the fibrin. That's how normal fibrinolysis works. So the antifibrinolytics, the way they work, these lysine analogs, which we looked at were Amicar or tranexamic acid, look similar. They have a lysine binding site, the plasminogen binding site is open. They fill this spot. Therefore, when this plasminogen gets down here, it can't bind to the lysine site on the fibrin. Therefore, no fibrinolysis occurs. And TPA is very angry. The serine protease inhibitors, aprotein, acts a little bit different. It doesn't stop the release of plasminogen to plasmin. However, once it's formed, it blocks its ability to break down fibrin directly after it's formed. So when we look at some of the data, the BART trial, they actually looked at a comparison of aprotein, which is one type, versus the lysine analogs in high-risk cardiac surgery. So what they found was, and this is 30-day mortality rates, is that aprotein is the red line, which is on the bottom. Epsilon aminocaproic acid, or Amicar, is black, and tranexamic acid light blue, dashed. That the mortality rate, there was a significant difference. More patients died with the use of aprotein than they did with the lysine analogs. So some of the explanations for this is that maybe aprotein really wasn't doing anything at all, and that rather that tranexamic acid and Amicar led to improved outcomes compared to not giving anything. But when they started looking at the bleeding, they noticed that the bleeding rates were improved, and that it may be that aprotein is such a good antifibrinolytic that it tips the scale too far, and they actually have clotting issues that led to their higher mortality. The other thing about aprotein is that it inhibits other serine proteases like kallikrein, which produces bradykinin, and vasoconstriction, and there may have been some result in organ damage. But as a result of the BART trial, there was over 2,300 patients. When they found out that more patients died when you gave them aprotein, it was pulled from the market. There were multiple meta-analyses looking at aprotein because some people couldn't believe that that was the case. But they did show that the mortality with aprotein was a relative risk. You have a 1.5 times greater chance of dying if you used aprotein versus the lysine analogs. Now, it's been reintroduced in the European markets. They're using it again. It's been restricted to investigational use in the United States, but it's not been used in the U.S. since 2008. But it was used in cardiac surgery. TXA, or tranexamic acid, is a synthetic derivative of lysine. Now, it's used in all sorts of countries, and I kind of put some of these up there because when we get to the trials, you can see that the U.S. is actually kind of behind on this. But many other countries have TXA, and it has its various names. And it binds both the plasminogen and plasmin. Okay. It was first described in 1966, and then it was a first trial reported in 1968, and it was used for menstrual bleeding. It's also been used in managing hemorrhage and dental extractions in hemophiliacs, and that's actually the only FDA-approved indication for tranexamic acid is for hemophiliacs. Throughout the 70s, it was used a bunch of different ways, which are all listed to see does it help bleeding and all this, and actually all of these cases showed that it was helpful for all of these indications. And it was also used in cardiopulmonary bypass and liver transplants, and has also been shown to reduce the need for transfusion or blood loss. Tranexamic acid, or its long chemical name, synthetic derivative. It also blunts the inflammatory response that is thought to contribute to the development of multiple system organ failure from shock. It's similar to Amicar, though it's 8 to 10 times more potent than Amicar. And most often it's given IV, but it can also be used topically. It's very effective in the pericardial sac, and it's also used in orthopedics in the joint capsule after joint replacement. And it's currently being used here by a couple of the orthopedic surgeons, both IV and for one dose, and they also they inject it into the capsule at the end of their surgery. So there is actually a lot of data about antifibrinolytics, and Cochrane Database did a review in 2007 and then updated again in 2011. And there was over 252 randomized controlled trials regarding antifibrinolytics with over 25,000 patients. And basically what they found is that in any kind of surgical patients, TXA reduced the need for blood transfusion by a third, and that they appeared to be free of serious adverse effects. Because you wonder, if you prevent fibrinolysis and allow them to clot, is it going to go the other way? Are they going to clot too much? And that does not appear to be the case. And I put this graph, this is called a forest plot, because when we get to the CRASH trial, which is the big data trial that supports the use of TXA in trauma, almost all the data is presented in a forest plot. What a forest plot is a different statistical way to present data, and basically what they do is, on the bottom, you have, is the drug better or is the drug worse, and then the vertical line in between is where it has no effect one way or the other. And so anything that appears on this side shows that that was better, and if it shows up on this side, it's worse. If it shows up on the line, no data, it didn't show if it had any effect one way or the other. Then when you start looking over here, the diamond shape, this is kind of like the low end, the high end, and the average is kind of in the middle. And then when we get to the other data, you'll see a bunch of variables lined up. They'll all have black boxes on the line, and that basically is proportional to the number of patients in that group. So a small box means there were very few patients, and a big box on the line means there was a lot of patients in that group. But they used this forest plot in the CRASH-2 trial, and we'll look at that. So they began a trial in trauma called the CRASH-2 trial, which was a randomized controlled trial among trauma patients to see, does antifibrinolytic drugs help in trauma, they decrease mortality and transfusion requirements. So they enrolled over 20,000 patients, 274 hospitals, 40 countries. Now the interesting thing about that is that the U.S. flag does not appear down here because there was not one single United States patient. The Canadian flag, there was only actually 2 Canadian patients. All the rest were from other countries. So this was a large trial done outside of North America. And when you hear any complaints about the CRASH-2 trial, all comes from this randomization slide. But to be eligible in the CRASH-2 trial, trauma patients had to be 16 years or older with significant hemorrhage, which was defined as systolic blood pressure less than 90 or heart rate more than 110. And be at risk of significant hemorrhage, which was a judgment call, and it had to be within 8 hours of injury. So right here is where the biggest controversy of the CRASH 2 trial comes from. These statements: doctor reasonably certain that no antifibrinolytic agents are indicated, or doctors reasonably certain antifibrinolytic agents are contraindicated. So if it didn't fall into either of those two, the doctor was substantially uncertain as to the appropriateness of antifibrinolytics or not. They were randomized. But all they had to look at was systolic pressure less than 90 and heart rate over 110, and they could make it into the CRASH 2 trial. Be over 16 in less than 8 hours. So there really were not a lot of patients who were deemed to be ineligible. And they were then randomized to either get TXA or placebo. So they randomized 20,211 patients, 10,000 to TXA, 10,000 to placebo, 3 withdrew, 1 withdrew. So they had around 10,000 baselines. They lost some to follow-up. So they had 10,060 for follow-up for TXA and 10,067 for follow-up in the placebo group, which I consider that's amazing for such a large number of patients that they had that kind of follow-up. So their dose of transexamic acid, they all got 1 gram over 10 minutes as a loading dose. It's given by slow IV injection or infusion. And then they got a maintenance dose with 1 gram over 8 hours. So a total of 2 grams of TXA. So when you start looking at the patient groups between the two, it was very well balanced between males and females, by age groups, time since injuries, the ones with less than 1 hour that got there started, 1 to 3 hours or over 3 hours, blunt or penetrating, very well matched, blood pressure ranges less than 89 and on down. It's just amazing that they had such a nearly even distribution in all of these characteristics just from a randomized trial. So here's when we get to the forest plot. So this vertical line, everything on this side means transexamic acid was better than placebo. Anything over here means transexamic was worse than placebo. Anything on the line means that the data doesn't support it either way. So if we look at time from injury, less than an hour, 1 to 3 hours, over 3 hours, it appears for less than 3 hours, TXA is better, and then the preponderance is that this is more to the transexamic acid is worse if it's over 3 hours. If you look at the blood pressure groups, all 3 blood pressures, whether it's less than 90 in this range or here, all were better with TXA. And remember, the size of the boxes is the relative value of how many patients were in that group. If you look at their GCS scores, all TXA was improved. By their injury type, blunt or penetrating, didn't make any difference. And if you get down to the bottom, all patients, there is an absolute improvement in survival of 1.5%. So 16% with placebo mortality, 14.5% with the TXA group. So that's 1.5% improvement over a 20,000 patient population. Most of the benefits were for bleeding deaths. And so here we went over our forest plot. TXA was better over here compared to placebo in bleeding, and the absolute death for just bleeding is the only cause, 4.9% versus 5.7%. Doesn't seem like much, but when we get to the later, you'll see that the numbers can add up. So what about treatment time? So if we look at less than 1 hour, we're way over here. That it's statistically significant if you can get it started within an hour. When it's 1 to 3 hours, we're still, TXA is better than not, but we're starting to slide towards the middle. And lastly, over 3 hours, what you actually saw was that you had a higher risk, 1.4 relative risk of dying when you get TXA after 3 hours. So the thing that came out of this is you got to give it within 3 hours, and if you can give it within 1 hour, you have more improvement in survival than you do 1 to 3 hours. So then we look at this forest plot again on, all right, so we're now stopping people from breaking down their clot. Then any of them have increased clot. And so remember, this side means TXA was better, this side means TXA was worse. If you look at DVT, pulmonary embolus, MI, stroke, or any cause, there's actually a slight reduction compared to placebo, but realistically, statistically, it didn't appear to be significant, and the bottom line was wasn't any worse, maybe slightly better. So after this trial came out, And it showed basically there's a 33% reduction in transfusions and a significant reduction in mortality. The Cochrane trial, which I showed, was updated in 2011 when the CRASH 2 trial came out, showed that in their analysis, if you went back and did it, they confirmed that there's a reduction in transfusion by 1/3 held up when you looked at all the other trials ever done. Ian Roberts, who was the principal investigator of the CRASH 2 trial, chalked it up to the recency and physicians' unawareness of the drug and its usefulness. He even did an audit of their own hospitals, and of the 412 patients they found to be eligible to get TXA, only 12. So the place where the study center was, only 3% of the patients who were eligible got it. So they were racking their brains, and they wanted to come up with ways to try to make physicians more. So they came up with this little ditty. They sent this out to all the doctors. Now, they obviously think different than I do about what gets a physician to give something. A choir singing a song. And this is annotated. It's like 3.5 minutes long. So they got this choir to sing this song, and they sent this out to the physicians to try and make them more aware in their own country. They also came out with this.
Systolic 100. Systolic 90. Giving blood. A clot stabilizer given within 3 hours of injury reduces the risk of bleeding to death by 30%. Check out the CRASH 2 trial.
That makes me want to give it right there. So I guess rather than sending the drug reps to the doctor's office there, they just make a cartoon and a choir. So is there any other data out there? Yes, the military has a series of trials. And the MATTER trial came out in February 2012. This was actually in Archives of Surgery. And they used a retrospective observational study comparing transexeme added to nothing, placebo. They only had 896 patients, not 20,000. But they found that, once again, lower unadjusted mortality than with the TXA than non-TXA. And the TXA group was actually more severely injured than the people who got placebo. And in their studies, they found that the benefit of mortality reduction was the highest in those patients who were massively transfused. Almost half, 14.4 versus 28%. And then the MATTER 2 trial came out in March of last year. It was a prospectively collected trial between the United Kingdom and U.S. military databases of patients who got one or more PAC cells. And then they looked at those patients to see who got tranexamic acid and cryoprecipitate, who got neither. It was an observational trial over 4 years from Afghanistan, and the thought was that cryoprecipitate is high in fibrinogen. Tranexamic acid prevents fibrinolysis. So if we can stop being broken down and give them enough fibrinogen, maybe that'll improve it. So despite higher ISSS and red cell transfusion requirements in the treated groups, mortality was lowest in the patients. TXA, 18.2%. If they gave them TXA and cryo, it was down to 11.6%. If they gave them cryo, it was 21. If they gave them nothing, it was 23.6. So tranexamic acid and cryo appeared in that small study that it did improve survival. But it was unadjusted mortality, and it was a small treatment group. So they recommended more study needed to be done. So the cryostat trial was done. It was a small trial completed in October of 2013, and it was a feasibility trial to see if they could get cryo into patients in a relatively short time frame. So they only wanted to enroll 40 patients. And so the patients either got standard treatment for massive bleeding, or they got an early dose of cryoprecipitate, and for them early was defined within 90 minutes in addition to standard therapy. And in their trial, the mortality was reduced from 33% to 14% by giving them cryoprecipitate. So they've now planned a second trial, the Cryostat 2 trial, and their plan is to enroll 500 patients to try and develop some power to the statistics to see if the same thing occurs in 40 patients, does it occur in 500 patients? An additional finding out of the CRASH-2 trials, they did a nested trial. Is that inside of the data of the CRASH-2 trial, they looked at the patients who had traumatic brain injury only. And this was planned ahead. It was called a nested trial, and it's also been known as the IBIS, I-B-I-S, intracranial bleeding study. And so they had to meet the criteria for getting a CRASH-2 trial, which you thought was easy. Over 18, blood pressure less than 90, or a heart rate over 110, or both. That's all it took. And they had traumatic brain injury with a GCS, which was less than 14, and a CT scan that showed they had traumatic brain injury. Of the 20,000 plus patients, there were only 270 patients identified as traumatic brain injury only, so they could eliminate all other confounding variables. And so the primary outcome was increasing in the head bleed size, whether they got TXA or not. And what they found was that there was a non-significant reduction in the hemorrhage growth. So the difference was 3.8 cc's less. That's kind of a hard call. I don't know how they measure cc's in the brain on a CT scan accurately, but they also know there are fewer focal ischemic lesions and fewer deaths. However, only 270 patients. But what it did confirm is that TXA was safe to give to the head injured patient. There's been a small caveat that subarachnoid hemorrhage might be a separate, but we don't really know. So the CRASH-3 trial is being started, and it's a transexamic acid for brain injury study. And it's international randomized double-blind control. And they're going to be looking at adults with traumatic brain injury. They're looking to get 10,000 patients. So far, they've enrolled 1,232 of 10,000 patients. So it's going to take some time, but hopefully we'll have the answer to, is TXA better, worse, or indifferent in the isolated head injury patient? As far as we can tell thus far, they do not see any negative effect on the head injury patient. So when I talked to you about that, there was an absolute 1.5% difference in mortality in the CRASH trial, 16% versus 14.5%. 1.5% didn't seem like much, but when you apply it to 20,000 patients, it gets bigger. Well, somebody went through and identified 18 studies where they had 17 reports where they had the causes of death. And they evaluated, and they kind of figured out that every year worldwide, there are 400,000 trauma patients who die in the hospital from bleeding. And then they used the statistics of improvement from the CRASH trial and applied it to all that group and said, if they would have gotten TXA, 128,000 deaths could have been avoided if you got TXA to those patients in less than an hour. If you do it in less than 3 hours, it drops to 112, but still it's 112,000 patients who would be improved. This caused the World Health Organization to add TXA to their box of essential medicines, which is basically the shopping cart where third world countries go to and say, okay, what medicines do we absolutely have to have? The World Health Organization added tranexamic acid to that box of meds. So how can you implement tranexamic acid in the emergency department? It's simple. All you need to have is the drug to be stocked in the emergency department. The staff needs to be trained and confident in using the drug. The drug's very simple to use. It comes in a 10 cc ampule. You put the 10 cc's in 100 cc's and you start the IV. The emphasis really needs to be on the people taking care of the patient. They need to think of it to give it to the patient. That's where the holdup, and the data was out there even in the country that ran the CRASH-2 trial, and only 3% of the people who needed it got it. The other thing is you have to communicate it to the anesthesia teams, or if the patient goes to the OR, and the ICU care teams, because this infusion then has to go on for 8 hours afterwards. So it's initial dose over 10 minutes, another gram over 8 hours. And this package is clear liquid. It's 100 milligrams per ml, and there's 10 ml, so there's your 1,000 milligrams. So to give the 10-minute bolus, you just put it in a 100 milliliter bag of saline and let it run through over 10 to 20 minutes. It doesn't have to be exactly 10 minutes. The 8-hour infusion, you put it in a 500 cc bag of normal saline and give it via an infusion pump over 8 hours. And if there's a gap between initial bolus and subsequent infusion, it probably doesn't matter too much, but ideally, one should follow the other. So if it's good to give it in less than an hour, what about giving it in the pre-hospital? And the remaining question was, is it still effective if you give it to people who aren't that injured? And so, because in the pre-hospital setting, you can't always tell how injured the patient is. You're going to say you got somebody who's injured in front of you. You don't know really how bad it is, but you know they need to go. How bad are they? So if you want to get to them earlier, there's not a lot you can look at. So they looked at the crash tube data, and they looked at the categories of severity of injury. So they looked at all their ISSs from less severe to critical, and they found that transexamic acid reduced mortality in all of them, no matter whether they were less injured or more injured. They just noted that patients who got transexamic acid had less bleeding and also had reduced incidence of myocardial infarction and stroke. So in 2011, this is out of Canada, an aeromedical program reported they started giving this in the pre-hospital. And their criteria was age over 16, major trauma, based on mechanism of injury, and a primary survey. So basically they're looking at, does it look bad? Do they have a low blood pressure? Are they tachycardic? Which is similar to what the crash 2 used. Heart rate over 110, blood pressure less than 90. And they gave the patients, and they found that in their group they used it 13 times, and they didn't notice any ill effect from giving it. So they proved it was feasible to use the protocol pre-hospital and give it, and that nobody was injured by doing it. Other aeromedical services started using pre-hospital TXA, including Mayo Clinic back in July of 2012. Australia uses it, British Columbia uses it, and the UK also uses it on their aeromedical services, pre-hospital. It's also already been used in Ohio. This out of the Columbus Dispatch, Ohio State University and Newark Division of Fire AMS, the first patient received transexamic acid. MedFlight was somehow involved in this because this came out of their little MedFlight, here's our newspaper kind of thing. That it was an injured patient who was going to be transferred in, and the patient did well, had no complications, but they were the first 30 people in Ohio to give transexamic acid in the pre-hospital. Some of the indications I could find for pre-hospital use of transexamic acid: patients over 18, hemorrhagic shock due to trauma, trauma less than 3 hours old, patients already received a liter of normal saline, if they have sustained tachycardia over 120 or blood pressure less than 90. That's pretty much, this isn't from one place, this is just from a series of things I could find of what patients have reported, or institutions have reported. There is a trial called the PATCH study, which is a 4-year trial. They want to get 1,200 patients. This is out of Australia. And they are going to be giving transexamic acid in a trial to look at its effect on mortality and recovery at 6 months. And they're also going to do blood testing, evaluation of its effect on coagulation, fibrinolysis, transfusion requirements, and other issues. So that's going on in Australia. They didn't really predict how long it was going to take them to get 1,200 patients involved in this study. So can the lab help us determine which patients should get transexamic acid? Right now we've got blood pressure less than 90, heart rate over 110. Traditionally, to measure fibrinolysis, the test is called the ELT, or the euglobulin lysis time. So they take platelet-poor diluted plasma and they allow it to clot. And then after it clots, they wait for it to see how long it takes for it to lyse. And this is normal is anywhere from 60 to 300 minutes. So 5 hours from now, they might be able to tell you whether there's fibrinolysis going on or not. So not really helpful. In addition, the prep time can take more time as well, so it can be well more than 5 hours. Now, a couple years ago, I did a talk on TEG and TAM thromboelastography. Can you use that? As part of the curve, after the clot forms, you get to see how it forms, and then you get to see if thrombolysis is going on. And they look at LY30, at least in a TEG, they use LY30, which is percent of clot lysis at 30, when it gets to 30%, or 30 minutes. And normal is defined less than 7.5. If it's over 7.5, you have more active thrombolysis going on, and then they say, okay, you would want to give transexamic acid in that. So what you would see is this. Now, you may not remember, but this is what a TEG graph looks like. And what's supposed to happen is the intrinsic pathway is defined by this line, how long it takes clot to form, and then you start to see the clot, and then clot strength, and you're supposed to see a big U. And so what we see is the clot goes up, and all of a sudden the clot starts to disappear. So there's fibrinolysis going on. And I don't know if you can see this, but the LY30 is 40.5%. Normal is supposed to be less than 7.5%. And there was actually a study presented at the Western Trauma this year where they said that if your LY30 was over 3% in a trauma patient, those patients are having active fibrinolysis. So even at 3%. So this patient here got transexamic acid, and this is their curve after treatment. This is what a normal TEG looks like. Goes up, clot strength is measured by this, the distance between these two, the MA is what it's called, and you don't see it break down. So this patient got transexamic acid, and they redid the TEG, and this is what it did. So the lab can't really help us. In addition, they did a study where they looked for occult hyperfibrinolysis, and so they looked at 303 trauma patients, and they used thromboelastometry, or the Rita machine, and they only identified 5% of the patients had an abnormal lysis time based on the machine. However, when they started looking at plasmid and antiplasmid complexes and D-dimer, 57% of the patients actually had fibrinolysis going on that was not measured by TEM, by ROTEM. So it's not sensitive enough to see that you need to give it or you don't need to give it. So basically what they're saying is TEG is not going to help you determine in the ED if that patient has got active fibrinolysis or not. So the lab can't help us figure out who should get transexamic acid or not. Groups at LA County and Houston found that as your ISS goes up, they had increasing incidence of having hyperfibrinolysis. Denver and San Francisco groups found the opposite. Shock on arrival, hypothermia on admission, and base deficit were all clinical indicators which were found by all four groups when they looked at reasons to give TXA. All four groups did find that if they were hypothermic or they were in shock and had a base deficit, those patients all had hyperfibrinolysis going on. Once again, if we go back to the crash 2 entry thing, blood pressure less than 90, heart rate over 110, they gave them transexamic acid. So we're back to this. Heart rate over 110 and blood pressure less than 90, or both, was a reason to give it. So transexamic acid is associated with an absolute 1.5% reduction in all-cause mortality for those patients that have blood pressure less than 90 or heart rate 110. It has its greatest impact on the severe shock group, 14.9 versus 18.4%. Giving it less than an hour is associated with the greatest reduction in mortality. It has not been associated with vascular occlusive events, i.e. increased risk of DVT and PE. If you give it after 3 hours, you increase your risk of death, and it's actually quite inexpensive. This is from our pharmacy. Nathan from the pharmacy gave me the CHP thing, and it's $76.32 for one dose, and then if you give it, it's twice as much. So it's $152 to give the 10-minute dose, and then $152 to give the 8-hour dose. So it's not really that expensive compared to factor 7, TCC. So it's pretty cheap compared to a lot of stuff we give. So I think it's time that we start giving our trauma patients transexamic acid in the emergency department. I also think it's time that we consider adding it to some of the pre-hospital protocols. CHP has limited transexamic acid to trauma only, I think. I found Nathan from the pharmacy sent me this big thing from the CHP. They must have some main pharmacy group or something, and this was in it. It is recommended that parenteral TXA be added to the formulary of CHP facilities that are accredited trauma facilities for early administration after trauma. Each institution should develop guidelines for administration, and this is from the CHP main pharmacy thing from January 2012. There's a lot of other non-FDA approved indications. Presenting perioperative bleeding with cardiac surgery, spinal surgery, blood loss and total knee replacement, C-section, postpartum hemorrhage. There's a large trial called the Woman Trial where they're using transexamic acid to decrease bleeding deaths from postpartum hemorrhage. And they're especially interested in this in these third world countries that don't have a lot of blood products, don't have a lot of other things. Transexamic acid is pretty cheap. It's actually more like $5. In some of the third world countries, you can get from the WHO for $5 instead of $76, and there's no upcharge for giving it, so it's $5. So it'd be helpful in those countries. Orthognathic surgery, face reconstructions, elective C-sections, and hereditary angioedema, in addition to people that it's already FDA approved for for bleeding. So I think it's time that we add this to our trauma protocols and give it to these patients. And it may be time for the pre-hospital providers to work with their trauma medical, their directors, which are usually our ER physician, to consider adding it to the pre-hospital protocols, because it's already started in the state of Ohio. So you never want to be last. And that's what I have for the presentation, if anybody has any questions. Yeah?
What's the shelf life on the medication if we're going to give it pre-hospital? How long?
I knew I should have brought that thing. I'd have to look it up. It's long. That's why they carry on squad. It's long half-life. I have the thing from CHP. I didn't really pay attention to that because I didn't think it was really important how long it lasted. It wasn't on my radar of what's important. I can get that to you. It's sitting on my desk over in my office, actually.
Then how long are the effects? How long does it last in the system?
Its half-life's about an hour. It's renally cleared. Now, when you look at the description on the drug and from the CHP formulary, it says, you have to cut down the dose in patients with renal failure. Well, you know what? You don't know that in the ED. And they didn't know that in the crash trial. They didn't screen out 20,000 patients because of their renal function. They looked at them at the door and said, if you're over 18, your blood pressure is less than 90, your heart rate's over 110, and I don't think there's a reason not to give it because I don't know of any other, they give it. Now, some contraindications from some of the other trauma centers is if you're anticoagulated, they don't give it. And if you've undergone a cardiopulmonary arrest, they don't give it. But they didn't really look at any of that stuff. So they did not adjust the dose for its use in trauma based on renal function.
Let's say you use it in a trauma patient, 3 days later, everything's stable, 4 days, start on love knots, is that possible?
Yeah, I mean, I don't think you need to treat them any differently than you would anything else. But it's clear, I was surprised at how much data there is. There was over 250 trials out there using TXA for years in surgery patients. And they all showed you can reduce the need for transfusion and bleeding in all sorts of surgery patients. Currently, Weiser and Patterson are using it in their total joints. They're giving a dose pre-op, and they're then injecting another dose into the joint capsule. And what I heard from Lynn Lawson yesterday was that thus far they have not had to give blood transfusion to any of the patients they've given this to since they started giving it. Now, who knows if that data is going to hold up. They've just been doing it for a few months. I wasn't quite sure how that got started because there's data out there for using it in orthopedics. But the information that Nathan gave me from the pharmacy basically said, yes, trauma centers can use this in trauma patients. It didn't say anything about using it in any other kind of groups, even though there's other data out there. And I can think of, I was on call, Bill Sugar called me, and they had some girl up in the OR who was postpartum hemorrhage, who was bleeding like crazy, and they'd given her everything in the cookbook, and they wanted to know if I had any other ideas. I didn't even know if we had TXA on the formulary. I know we do now because Patterson's been given it. I don't think we did at that time because it was just approved for CHP pharmacy formularies to have it a year ago. That would have been nice to give. I mean, it doesn't hurt you, and it's cheap. Not like $20,000 factor 7. Okay.